I'm Ed Stiles, and I'm going to be presenting today a unique way of screening patients with musculoskeletal problems, or some people call it the mesokinetic system, since it's all derived from the mesodermal layer of the embryo and has to do with kinetics. And I view the body as a very complex, unique system that each patient has to be treated as one-of-a-kind patient and has to be treated uniquely. So I'm going to be demonstrating and discussing how you approach that patient to develop a unique screen for that particular patient. Now, this screen is based on a screen that Fred Mitchell Sr., one of my mentors, utilized, but it has been expanded tremendously over the last 30 some odd years. The other thing is, what we're trying to find is the somatic dysfunction that's the area of greatest restriction or hindrance to that body's functional potential. And what it can do is change the motor control, and therefore, once the somatic dysfunction is appropriately treated, then the motor control tends to, in 80% of the patients, to go back towards a more normal range, whereas if it's been hyperactive before you started the OMT or hypoactive, usually the tendency in both groups is to go back towards a more normal range. Many people that do manual medicine, there's several different approaches. Some are well thought out linear type approaches that have been derived by many different people using different models. There are also 5 osteopathic models that some people use, and the others is people can chase pain. But the problem is the patient's body hasn't read the book, and many times those models don't pan out all the time, and so therefore what we need is a unique approach for each patient, and that's what we will be demonstrating. In the Biotensegrity book by Graham Scarr, he quotes Tom Myers as saying that we want to find maps for patients so we don't do what he calls press and pray. Well, I think each patient has their unique map, and that's what we'll be demonstrating in the screening exam. So, Jackie, let's have you stand over here. Now, with that camera, woohoo, I'm running out of cord here. Is it going to be better? Yeah, this will be good. Let's have you turn on my. So, what I'm doing is, I'm evaluating. This whole screen is based on Fryette's laws of physiological motion. And the third law says that if you introduce one motion, you restrict the 2 other motions. If you add a second motion, you restrict the remaining 2. If you put a third motion in, you restrict all 3, and you have a ligamentous or a physiological locking. And in that case, when you spring each segment individually, there'll be some joint play, as Manel called it, or there'll be a little give to the tissues. Whereas if you have an area of somatic dysfunction, when you start stacking those movements on top of each other, the nervous system can't tolerate it, so it guards and produces guarding, and so you have increased muscle tone around that area, and it causes a restriction of the joint play, and what you're looking for is the area that has the hardest end field and the least amount of motion. And many times that area is in a totally different area of the body than where the patient's chief complaint. And let me just give you an example. Recently, one of the residents came to me and said, I've got a patient that is a former coal miner, had multiple injuries, the thoracic area and rib cage area is locked up, can't get any movement in it at all. It's just like it's been welded together. So whenever I check a resident like that, I like to try to confirm what they're feeling. And when I examined the patients, I agreed. It felt like there was no movement in that thoracic area and rib cage according to the screen we're going to demonstrate here in a few minutes. But when I had the patients sit down, all of the dysfunction disappeared, and there was good movement in the thoracic area and rib cage. So what that meant was, when the patient sat down and got off their legs, that the area of greatest restriction was somewhere in the legs. We found a distal fibula dysfunction. Then the patient said, oh, 20 years ago I fractured that, I've got hardware in there, And when we treated that, stood the patient back up, the thoracic area and ribcage mechanics were markedly improved. Well, you could have easily got sucked in to try to treat the thoracic area and ribcage. You wouldn't have gotten a good outcome with that patient. Now the screen, the first thing I'm doing is getting a hand on the head, but getting my thumb right up on the tip of my thumb at the occiput. And I want the thumb over the articular column. And so on the same side as I'm standing on. And then my fingers on the opposite side can monitor motion and on how the soft tissues are moving. And from here, I can put a slow gliding side bending and rotation movement in there. And what I'm monitoring with that thumb, does movement go down smoothly down through that area? And do the muscles stay relaxed on the other side, or do they start to tighten up and start to guard? And you're going to do this on both sides, so that I'm just going to be demonstrating it on one side. But that area, so then that says to me, with this patient, there's pretty good movement in that cervical area. So that says to me, there may be a little tightness here, but that's not enough to really get me concerned yet. So then the next hole is, I'm going to put the tip of my thumb where the base of my thumb had been. Now I've got a group here of where I'm monitoring several vertebrae. Now I'm going to use the shoulder as to introduce the motion. Oh, Jackie, let me have you turn around a minute. Let's do it this way. And this hand over here, I've got my thumb over the spinous process, the scapula, but I've got a finger above the scapula, a finger below the scapula. Then I've got a couple of fingers over the upper ribs. So then that way I can introduce side bending and rotation. And if I do that, what it is, this third law says it restricts the flexion extension, then just gliding my hand forward and back is enough to introduce the flexion extension. So now let's come back here again. So that's where you're seeing what I'm doing with what's called the motion introducing hand. Now the hand, my thumbs are over the facets, so they're lateral to the spinous process, medial to the transverse process, and I want that thumb right over the articular column, because this is what I'm trying to monitor, is what's going on in the joint mechanics. And you want to blend in enough where you get through the tissues and get down to the bony level, because if you have a real soft touch here and you put movement in, all you're doing is monitoring the soft tissues and the fascias. Whereas if you get your thumb on there and you side bend till you feel movement start at your thumb and go down to the heel of the thumb, then introduce rotation slowly and gently, you're stacking that on top. And then it just takes a little gliding of the hand forward and back to introduce flexion extension. And as I do that with this patient, I can feel movement come right down through there. So that says to me, that area looks pretty good. Then, and what you want to do is blend in with the tissues, and don't do fast jerking type movements, because if you do, you can spook that nervous system and it doesn't know what's going on. It'll start to guard and protect. So you want to do things gently and slowly, and you're blending in with that body. So then I'm going to move my hand down to hands grip down and check the mid-threat. Now, as soon as I start to introduce a little side bending and rotation with our patient here, it starts to restrict right here. And so that tells me there's an area in there that I don't like, that's tighter than anything I found here or in the cervical area. Then I'm going to go down below that. And when I introduce the side bending and rotation and the flexion extension, I feel pretty good movement there. I can go down over the lower lumbar area and go right down over the sacroiliac area. So what you're doing is you're monitoring motion from the occipital area all the way down to the sacroiliac area. Now, with our patient here, when I'm feeling a little restriction here, that says to me there's a group here that aren't working right, but then I can hold her in that side bending and rotation and use my thumb to diagonally spring across. You're going across 3 planes of motion, and a normal joint will tolerate that. Dysfunctional ones won't. So there's a little spring, there's a little spring, but boy, right there's no spring at all. So in this patient, as Mitchell used to say, I don't care if she's complaining of fallen hair, fallen arches, or anything in between, where I would start with her is in this area here, and then we'll talk a little bit later about how to problem solve that. But you're going to do that screen on both sides with the patient standing. Then you want to have the patient sit down. Jackie, let's have you face that way. And I think come up at the end of the table here, yeah. And then we're going to do the same screen again sitting, because we want to see if it changes. Because if things lock up when she's standing, that means the lower extremities are playing a role. If it gets better sitting compared to standing, that tells you her legs were helping her to compensate, and therefore the legs aren't a key player in the dysfunction. So then again, I would do the same screen, and again, do it slowly and deliberately, and I'm going to go right down over the whole spine, right down over the sacroiliac joints, and again, do it on both sides. So you're doing this screen bilaterally, both standing and sitting. And that seems so simple, but many times, because you're using that third law of spinal mechanics, you bring up the dysfunctions that previously have been hiding. Okay, I'm going to, let's have you stay right there. Now, how do we problem solve this? That's the fun part, because if the area of greatest restriction is cervical area, or let me go back a step. The first decision you make after you do the screen bilaterally, standing and sitting, is the area of greatest restriction or hindrance in the upper half of the body or lower half of the body? And the breakoff point is T12. So T12 is the bottom of the upper half, it's the top of the bottom half. Then if it's the upper half, you have to ask yourself, is it cervical, thoracic, rib cage, or upper extremity? And here's how you sort that out. If it's mostly in the cervical and it's in the upper cervical area, and it feels like the soft tissues are fighting back at you as you get to the end range of motion, usually that means it's either OA or AA or both. But as you get them up against that range of motion, if the tissue's there, the muscles don't fight back at you, but it feels like you're palpating leather, usually that means it's dural. Then that means you need to go into the cranium and we don't have time to do today, but a cranial screen to find out what are the key sutural dysfunctions in the cranium. If it's lower cervical, the typical cervicals, then find the one that's most dysfunctional by springing segment by segment as you got the side bending and rotation or flexion extension in there, and find out which one is most restricted, diagnose and treat that. Now, anytime you treat an area of greatest, well, let's go with the next area, the thoracic area. The questions are, is it thoracic spine, is it rib cage, or is it upper extremity? And as you come down with Jackie, we found mid-thoracic function right here. So then what I would do is keep the side bending and rotation in there, but spring laterally out along the related rib. And if it gets tighter and resists you more as you spring laterally, that usually means the rib cage is the key player. If it gets better as you go laterally, it means the vertebra is the key and you should treat the vertebra. Now, if it's the rib cage that's restricted, then you got to have the patient lie down or screen the thoracic rib cage area to see what are the rib patterns, what is the key rib in those patterns, and then treat those out, the key dysfunction or hindrance in the rib cage. So some people teach always treat the thoracic area before the rib cage. Others say treat the rib cage first, then the thoracic area. They're both right, they're both wrong, depending on the patient. Because sometimes when this is tight here, you got to treat the ribs first. Sometimes you got to treat the spine first. But this will help you to differentiate that. Then other times when you do a screen, you'll find the traps are tight, the rhomboids are tight, there's a vertical band of tightness all along the medial border of the scapula. And when you find that, it usually means there's something in the upper extremity that's dysfunctional. So then screen out SC, AC, particular radial head, wrist, hand, and see what's it. And I've had patients where that area was so tight on one side and not the other side that if you were blindfolded, you think it was two totally different people. Then screen out and find out it's like a radial head dysfunction. Treat the radial head dysfunction, come back up and find this is all relaxed. See, and when I was in school, I was taught to massage it, treat it, and stretch it, and trigger point it, and inject it, and do all sorts of stuff. And then when I finally figured out this phase and treated out that radial head that day and saw this change, I thought, wow, this is amazing how this body tries to compensate and adjust. And only a tensegrity system could do that. So that would be the upper half of the body. Now the second half of the body, we need to do a sitting and a standing forward bending test. I'm going to do those here. Let's have you, well, I'll do the sitting forward bending test first. So the sitting forward bending test, you're palpating the posterior superior spines, and you want the patient to bend forward. Now let's have you bend forward for me. And the thumb that rides cephalad, that's the dysfunctional side, because it means it's lost the joint play in there. So you do a sitting forward bending test, and that's usually testing more sacral mechanics in relationship to the innominate. Whereas if you do that same test with the patient standing and bending forward, you're testing the innominate in relationship to the sacrum, and you're testing the inferior transverse axis function, whereas the sitting tests the middle and the oblique axis functions. Now, if the standing forward bending test is a lot more dramatic than the sitting forward bending test, that usually means there's something in the legs that are the key player, and usually it's below the knee. So it's frequently fibula head, distal fibula, tibial rotations, foot or ankle problems. If the sitting forward bending test is more dramatic than the standing forward bending test, that usually means it's either lumbar area, sacrum, or pelvis. And how you weed that out is when they come back up from doing their sitting forward bending test, rescreen over the lumbar area and over the sacroiliacs, and if it's more over the lumbar area, then segmentally check to see which one is the key dysfunction, diagnose and treat it. If it's over the sacrum, then I think Mitchell in his axis model had the right sequence. You want to get the up shears and down shears out first because they disrupt all three transverse axes. If you don't have an up shear, down shear, but if you have a pubic shear dysfunction, you want to treat that out because of that long axis arm that can markedly affect posterior sacroiliac mechanics. If then after you've treated the pubes, then you treat the sacrum, and once the sacrum is functional, then all the transverse axes, all the oblique axes are lined up. Now it's easy to treat the innominate rotations and the inflares and outflares on the inferior transverse axis. So when I do that screen, see, I can identify where the area of greatest restriction or greatest hindrance is. Many times it's in an area of the body that's totally asymptomatic, and many times it's totally unrelated mechanically directly to the area where their chief complaint is. And many times the key area or area of greatest restriction hindrance is in a totally asymptomatic part of the body, distant from where the chief complaint is, and it's very localized and has a very hard end field. Whereas people get sucked into when there's a dysfunction, that whole tensegrity system adapts and adjusts, and many times they get sucked into the big areas where there's soft tissue changes and things like that, whereas the area of greatest restriction hindrance many times is a real small area elsewhere in that area, or it may be somewhere in that diffuse area of compensation. So you're trying to find that key area, and whenever you treat the first key somatic dysfunction, redo your screen because you'll be amazed at how much stuff changes throughout the body. Then rescreen, re-problem solve it, treat the second area of greatest restriction hindrance, somatic dysfunction. Then rescreen again and see how much changed. Then do the third one. And many times when you've done 3 dysfunctions in the patient, you go back, you will have changed 90% of the dysfunction that you found in that body initially because they were all compensations. See, and many people try to treat those compensations with manipulation or fascial techniques, and they don't get good outcomes because they're secondary to something else. And when you find that key area, then you get a lot better response with the treatment procedures. So let me make sure that I have covered all the points that I want to cover, and I think I have. So, when you treat the somatic dysfunction in those area of greatest restrictions, you're making, or can make many times, major motor control changes throughout that body. And the tendency is when you treat those for the other areas of the body and that area, to whatever you're using as measuring tools, to back towards a more normal, healthy pattern rather than hypermobility or hypomobility pattern by your testing procedure. And what's neat about this screen and this treatment, you will never treat 2 patients the same. You will never treat the same patient the same on each subsequent visit, because each time they're changing and adapting and things. And this approach then honors the uniqueness of each patient and the complexity of each patient. And like I said, each patient is usually a unique, one-of-a-kind patient. And so it's fun. The good news is you can get some great results doing this. The bad news is you got to do a lot of thinking, a lot of problem solving with each treatment. You can't do it by rote and by protocols. Thank you.